Good morning, everyone. We were just waiting for Martin, but I think we'll make a start because Martin is here now, so well timed. Just to remind everybody, this will be recorded, and I think we are on there. I think I just got the thumbs up. So, welcome to this meeting of the Adult Social Care and Public Health Select Committee. And I'll ask for the committee to approve the minutes of the last meeting, please. All those in favour? Okay, that is approved. And I will ask the clerk, are there any apologies, please?
Yes, Chair. There are two apologies. I have apologies from Councillor Carr for medical reasons, and Councillor Williamson is substituting, and I have apologies from Councillor Fielding with Councillor Creamer. I also have apologies from Councillor Hinshaw with no substitute. Chair.
Thank you. Welcome to the three members for today's meeting. Right, declarations of interest. If any councillor or officer has an interest in any matter on the agenda, you should declare it now. Please raise your hand now if you have an interest to declare. If you have an interest to declare, you should state whether the interest is, what the interest is, and give brief details. Anybody got anything to declare? Nope. Thank you very much. We'll move on to agenda item 4 now, on the main agenda, and that is the mental health services support within the adult social care and public health. And I'll call upon Councillor Matt Barney to introduce this report, please.
Good morning, everybody. Good morning, Chairman. I don't know about anybody else, but I, for one, found the request of this item incredibly helpful and the report incredibly helpful because obviously the way this local authority interacts with mental health services is somewhat complex and touching on a lot of different bodies and institutions across Nottinghamshire. And I just think it's helpful perhaps to, it was helpful to me in any case, to draw members' attentions to pages 23 and 24 where there's and 25 where there's a fairly simplistic diagram that details how the services interrelate and operate depending on the specific healthcare need and our relationship with the resident or patient in Notts. But to expand upon this further, I'd like to invite Ainsley if she could talk us through the paper. Thank you.
Yes, thank you, Councillor Barney. Catherine, will you be sharing the slides, or Martin?
Slides.
Thank you.
Just give me a second, yeah.
So, just by way of introduction, so this item will be a combined effort between myself and colleagues, Katie Ball, Service Director for Strategic Commissioning and Integration, and Viv Robbins, Interim Director of Public Health. So I'll just give a second for the slides to go up on screen. Thank you, Martin. So this was an item that Select Committee had requested that we bring primarily to give an overview of the mental health system and specifically the services that are either provided or commissioned by the County Council. Can I have the next slide, please, Martin? And to describe the types of services that we provide. One of the elements was to describe the role of our approved mental health professionals, and I do have with me a colleague, Claire Sawyer, who is a practicing AMP, and you'll hear more from Claire later in the presentation. And also the presentation seeks to outline some of the challenges that we face at the moment, but also some of the opportunities that we have ahead of us. Next slide, please, Martin. So one of the key things that we want to outline for you is an overview of the mental health system offer. Now, when we say system, what we mean is the system in its widest sense, so not just services that we provide, but giving some clarity as to the types of services that are provided by the NHS. So for anyone concerned about their own or someone else's mental health, the first point of contact tends to be with the GP. And the GP's role is to make an initial assessment based on how that person presents, and then offer advice or signposting to other services or referral to other services, depending on what the need is. So GPs may prescribe medication, they may refer to talking therapies or other forms of counselling. They may refer on to secondary mental health services, so by and large the services that are provided by Notts Healthcare Foundation Trust, or they may and can refer to adult social care as appropriate. So that would be for planned NHS access to planned NHS services. However, people quite often come in through points of crisis as well, and it may be that someone has an acute mental health episode, perhaps at home, perhaps in a care setting, for example. And that's where Notts Healthcare would become involved, either through their crisis team or psychiatry, and it may be that the person ends up with an admission to mental health inpatient services. So as you can see, much of those, sort of the initial interventions within the mental health system would be with the NHS, it wouldn't be with the council. However, we do have quite a broad spectrum of services that we provide to support people with mental health needs, and those requests for support may come in through our customer service centre, so it could be the individual or the family call us up and want some perhaps advice and guidance which we can give them. It may be that we feel that our maximised independence service and reablement is appropriate to that person to help them to maintain their independence at home and to keep them well and to keep their lives functioning and on track. It may be that customer service centre actually refer through to our adult social care teams for social care assessment, and from that we can then plan and arrange further support. So again, that would be our planned approach, but equally we also have unplanned access to social care services, and that would tend to be through our AMP team, so our approved mental health practitioners, and Claire here is one of those practitioners. And those referrals can come through from anybody. It could be the GP, it could be Notts Healthcare's crisis team, could be the police, hospitals, families, other social workers, care homes. Those referrals can come through from anywhere, but it is at the point that someone is in crisis and their mental health is extremely poor. Can you move on, please, Martin? And I'm just going to hand over to Viv now.
Thank you, Ainsley. So Ainsley's obviously talked a lot around in terms of accessing mental health services, and this slide here really talks around how we can do that work around that preventative agenda, because we would always want to support our population to have the best health and wellbeing, including that from a mental health point of view. So in terms of what we've got on the slide here, there are a range of services that the council provides in terms of supporting people to have a really positive emotional and mental health. These range from a range of promotional work, the public health lead, really ensuring that we have that consistent approach to mental health promotion, and doing a lot of work around that suicide prevention strategy, and that's an area that we will cover in this meeting later on in the year. There's a lot of work around early help and ensuring that we have really strong, resilient communities. So we've got work around community friendly Nottinghamshire. We've got work around local area coordinators, health and wellbeing champions that are really working at that very local level with our communities and our voluntary and community sector to support our communities to have that building that higher resilience level and that emotional support within their communities. Ainsley's touched on some of the re-ablement support already, so really thinking around through the maximising independence service in living well social care teams, how we're really making sure that that lower level of social care is very strongly implemented across Nottinghamshire to really help people have that positive health and wellbeing and remain independent in their home settings for as long as they possibly can. And obviously that links to physical as well as mental health elements. There's a strong ethos across the department around the 3 conversations approach, and really ensuring that we're embedding that strengths-based practice to really understand what is important to our population and our people, and supporting them to find solutions that really meet their needs at the spaces that they're at. And that really then works with them to support them to have that lower level of support that will then hopefully stop them from needing longer-term, more intensive provision at that time. And as you will be aware, there's also a lot of work around the preventing hospital admissions. So I won't go through the work of the AMP service later on, because we know that Claire's doing some of that, but really building on some of the work of the reform project and really hoping to do that hospital avoidance work that we can. So next slide, please. So in terms of just some of the other work that the services that are delivered directly by the council, we have a range of services that basically support the Statutory Care Act work, some of that broader social care work, occupational therapy and safeguarding work across the department. And that includes some specific teams which work with specific populations. So it might be those that are deaf or visually impaired, and all those that have other slightly different mental health needs. There's a lot of work going on with commissioning of services, and Katie's going to be covering that in a little bit, so I'll leave that to her. But then there's also some work that we're doing, particularly from a public health lens, around how we are supporting that broader approach to looking at how mental health is such an important part of our broader health and wellbeing. So how are we supporting having those really strong building blocks in place to make sure that we have a positive mental health and wellbeing as well as physical health. And some of those examples are thinking around how we're linking our services together. So how we're linking support in terms of substance use with our mental health support, and how that links into that broader agenda that Jonathan Gribbin talked a lot around in terms of his annual report around that severe multiple disadvantage, and how where we have cohorts within our population that have a range of factors that need support, many of those support needs build on having a strong emotional health and wellbeing within that package of care. So we're doing a lot of work around that. And then there's some more work around that community enhanced offer from an adult social care lens. So I think, am I handing over to Katie now, please?
Thanks, Viv. If we're okay to go on to the next slide, thank you. So I'm going to talk about some of the services that we use from external providers that we've put into place. So we have a moving forward service, which is short-term support through Framework Housing Association, which is helping people to address housing and money issues or benefit issues. And that tends to be, so that's community-based support, tends to work with people for about 5 months on a plan and that kind of support. Also looking at health and well-being, social connections, employment goals within that. and people often come out with an I plan, we call it. And secondly, the Moving Forward service has crisis liaison support. So we have 6 workers that can work alongside the crisis team when people have been admitted to hospital, which is also looking to resolve housing, money or benefit issues that might be exacerbating the crisis that's happening for that person at the time. We have care support and enablement. So staff that are working with people can find suitable providers to come and give support to people in their own homes, and that includes when they're in supported living support as well. And we have a whole range of providers that we can call off to get that support. We do have day opportunities for people, but they are quite limited because most people tend to have a personal budget through a direct payment so that they can have a very personalised package of support that we arrange with them and around them. And of course we do have residential care, and that includes some short-term support but also where people need some respite. In terms of carers, we now have our carers hub, so carers can access that advice and support and ensure that we're putting support around carers where appropriate. And we also have an organisation that delivers our statutory advocacy service, and that's to help people to understand their rights and be able to express their views about the support that they might need to access. If we're okay to go to the next slide, please. Obviously, we want to make sure that the support that we've got in place externally is really effective and that we're managing that well. So we have a range of ways to do that. So we have key performance indicators in all of our contracts, and that might be the levels of staffing that should be available in particular support, how quickly people should be being supported, and the types of plans and outcomes that we'd be wanting to look at. In terms of the outcomes delivered, obviously we're wanting to support people back to greater independence, building social connections, etc. And we might use self-scoring at the beginning and the end of support, and that might be people giving themselves a score in terms of how they feel. Do I feel optimistic about the future? How relaxed am I feeling? I feel useful, I'm able to think clearly, so that we can see that change for somebody throughout the support that they're receiving. We might have very specific requirements around qualifications of staff, minimum standards, who the particular provider should be working with in terms of joined up teams, etc. And we'll have quality standards within there. So that might be quality standards that we've set, or it might be national quality standards. For example, the Care Quality Commission CQC registration and inspection, or for example there's a national advocacy quality performance mark that we would want people to be meeting. And through every contract that we do, we try to drive social value as well. So that's thinking about those broader economic, social and environmental impacts. So driving further skills and employment and jobs locally, thinking about building more resilient communities, but also the environmental impacts and enabling staff that might be walking to be part of that workforce, recycling, etc. We're okay to pop onto the next slide, please. So this next slide gives you an overview of the spend in this area. So 23.4 million of council spend was around mental health provision in 2022 to 23. This is reflective of spend on 18 to 65-year-old adults and through public health. And you'll see that there's a breakdown there, but you'll see that nursing and residential care are our highest costs per person. But also that's the area where we get the most income and support through our ICB, so the highest contributions into those packages, which is 8.8 million per year. So I think I'm handing back to Ainsley.
Thank you, Katie. So I'm just going to talk to you a bit about the role of the AMP, which stands for Approved Mental Health Professional. AMPs are usually social workers, but can also be nurses, occupational therapists, psychologists, but they've been approved by a social services authority, in this case us as the council, to carry out certain duties under the Mental Health Act. They have many roles within the Mental Health Act, but one of the key elements of the role is to coordinate Mental Health Act assessments and make applications for admission to hospital if that's deemed to be necessary. So these are people that are really working at the sharp end of social care. They go into some incredibly stressful and difficult environments with people who are in real crisis. Other roles that AMPs can carry out might be assessing people for community treatment orders, whereby, as opposed to being admitted into hospital, it's felt that someone's care and treatment can be managed at home, or it may be a court-appointed guardianship where we've been appointed to help someone with decisions about their care, treatment or welfare. Just before I introduce and hand over to Claire, one of the things that we've seen over the last few years is quite a stark increase in the number of Mental Health Act assessments that we're being asked to undertake. So just for a snapshot, the total number of Mental Health Act assessments that we undertook in 2020 was 1,722. Last year it was 2,478, so that represents a 30% increase. So that's quite significant in terms of how we use our resources, but also in terms of the nature of the demand that is coming through our mental health services. We're also anecdotally seeing an increase in the complexity and acuity of people. That's a bit more difficult to narrow down, but certainly people are presenting to us much more unwell at the point that our AMPs get involved than we've seen previously. So just to give you a snapshot into the day in the life of an AMP, I'm going to hand over to Claire Sawyer, who is a practicing AMP.
Hi, good morning everybody. So as Ainsley said, my name's Claire. I'm one of your approved mental health professionals working for Notts County Council. Our team is a 24/7 team. We are operating from over the full 24 hours. There is always somebody available. We all work 12-hour shifts. That's done in 3 different shifts throughout the day, and then we operate through the night taking calls. Nighttime work has started to increase, predominantly in hospitals and police stations, because we try and respond within 3 to 4 hours when it's in a hospital or a police station. So our work is ageless. I think the youngest I've detained was 12 and the eldest was 99 years old. So we operate from border to border within the county, and we actually are available to everybody that steps into the county. So even if they're not a resident within Nottinghamshire County, if something happens once they're in the vicinity, if they're in our area, then it will come to this AMP team. So the expectation is that we manage that as well, which can create additional difficulties because then we're liaising out of counties for beds and transport, etc., etc. So our warrants, basically, it gives us the same power as a judge. We can sign an application and send somebody, deprive them of their liberty for up to 6 months. The power of the AMPs is quite significant, so therefore we use it very humbly, very respectfully, and with a lot of dignity. I think, the AMPs in Nottinghamshire are all really, really proud of the work that we do. Work has increased, the complexities, the challenges, as there's been restrictions and diminishing services. It puts more of a focus on our service. And I think, as Ainsley pointed out, people are in more crisis now when they come to us because there's not always the additional services that might have kept somebody quite well. We go wherever the body is. I've assessed people in car parks. We've had to take windows out, we've had to take doors off. So if once we've accepted a referral, which could have come from anywhere, once we've triaged it and we've accepted that and we've started that ball rolling, it has to then come to an outcome. So we operate from least restrictive right from the off. What else is being done? We push things back. Is this a delirium? Is it an infection? Is there other things that we can do before we accept that as a referral? Because once we have, it has to then come to an outcome. Whether that means it takes us 3 or 4 days of repeatedly going, have to go to court, get a warrant, bring the police in, and then coordinate going into somebody's house against their will. They're scared, they're frightened, they might have children, they've got careers, lives, neighbours, loved ones, pets. That all falls down then onto the AMP team, because we're not just working with that person, we're working with their families. The police are a really good resource, but they're understaffed as well. So we might organise something the police can't get, but we've got there with an ambulance, we have a doctor, we have a locksmith, and then we have to reconvene and all start again. It's just the nature. So it's very challenging, it's very emotional, but there's no other job in the world I could ever imagine doing other than being an AMP. We are very lucky in Nottinghamshire that we have the service that we've got, and we're building relationships all the time. Recently, we assessed an older person, very, very unwell, to the point where his wife had had to flee. They'd been married 47 years. Devastating. They've got grandchildren, but he did get better. Similarly, a 12-year-old child, mum and dad love him to bits, but that loving him to bits is, it's borderline neglect and safeguarding, because they're not allowing other people to do what they needed to do. He, unfortunately, now has been taken into hospital and he will get better, but it's going to take time. So we also have to make sure that we've kind of consulted with what we'd call a nearest relative. We take nearest relative work to court. We have to take it to court. We have to, identify who the nearest relative is. Some people have got one, some people it's not appropriate. So there's lots and lots of other stuff, as well as our statutory duties that the AMPs do. We do safeguarding work, and then obviously all our responsibilities as being part of Nottinghamshire County Council employees. But we do love it, even though it's very, very challenging, and it's very emotional. We are involved in such an intimate time in somebody's life. I think going through somebody's door and seeing how they're living and trying to pick up the pieces and make decisions that they probably can't make, it's incredibly rewarding, and we're all very, very passionate. Thank you.
Thank you for that, Claire. So, having heard from Claire about the work that she does, and as I've mentioned, in terms of challenges that we face, could I have the next slide, please, Martin? It is a really complex system within the mental health space, and there are lots of different services, as you've heard. Sometimes we overlap one another. Other times there might be perceived gaps, and people get lost trying to navigate the system. We do recognise that. As I've already mentioned, the demand is absolutely growing. It's certainly, from what I'm dealing with on a day-to-day basis, the biggest area of demand within my area, and we're constantly striving to keep up with that demand and use the capacity that we've got to best effect. We've worked really hard to try and retain our AMP workforce. We've invested quite a lot into that workforce, both to grow the team but also to retain the people in that team, because there is a high risk of burnout within that role, as you can imagine. We've had some other challenges. So although the Mental Health Act reforms have been delayed at this point in time, we do have other legislation that's come in. So, for example, right care, right person, that is something that the police are actively pushing forward with, that means that police are involved appropriately So one of the things is that quite often the police will be asked to go and accompany AMPs to execute a warrant or undertake an assessment. But they are now triaging the points at which they will actually come and support us, and they may not be able to do that in every circumstance, which puts a bit of pressure on the service. And then we've also got incoming social supervision, which is a Mental Health Act power that is undertaken now, but that's likely to grow and will add to the workload, if you like. However, it's not all bad news. There are some opportunities, and I'll hand back to Katie to talk through some of those.
Thanks, Ainsley. So we're looking at implementation of a market factor supplement. Oh, we've done it. We've implemented a market factor supplement, which is really important to make sure that we're doing everything that we can to retain these fantastic people that we've got in our workforce. Also partnering with Think Ahead to also help us address some of the difficulties in recruitment, because there are paid training and employment opportunities that we're galvanising through that partnership. It says here a housing tender is imminent, but actually we've issued that last week, which is great. So another really important theme through this is housing and appropriate housing for people. So we are seeking up to 96 units of accommodation across the county, and that is going to be supported living for people with learning disability, autism, as well as mental health. We're going to commission the care and support to people in their supported accommodation separately when the housing development is underway. And we have deliberately split those two things so that we can be more flexible about that support. We also have talked in our wider partnership about how we can really make sure that we are doing that planning together, and make sure that all of this support works in the most effective way. And so we've created 2 jointly funded posts across the County Council, City Council and the ICB. And that is to make sure that we are doing that planning together and to really start to push on maximising the support in the community, thinking about prevention more broadly and those wraparound services, as well as to prevent people escalating as much as we can, but also to look at the people that are in inpatient settings and support them back into the communities. And we've got some really good examples of how that has worked to build on. So I'm just going to hand back to Viv for the last slide.
Thank you, Katie. So just a few more opportunities that we think that are really important things that we need to consider moving forward. So we're just in a position at the moment where we're just reviewing the priorities around the integrated care strategy and making sure that the priorities that we set last year are still the right ones. And really thinking around how do we make sure through those 3 key principles or guiding principles of the integrated care strategy around prevention, integration and equity, that we're making sure that we're really getting a strong mental health lens through that work, because we know that people with serious mental health illness in particular have much poorer outcomes than the broader population. As I mentioned before, there are some more opportunities building on the Director of Public Health annual report, and really thinking around how are we making those links between domestic abuse, homelessness, substance use and mental health, with also some work around criminal justice, and really supporting that individual and that cohort where we know they have significantly poorer health and wellbeing outcomes, and mental health is such an important and crucial element around that. So there's a lot of work that's going on around the delivery of services to support that, but also that leadership piece around that. And then in June later on in the year, we will come back to you in terms of consulting on the suicide prevention strategy at this committee, where we will really demonstrate some of the work that Kath and the team has been leading in terms of that really strong public health leadership and coordination around the suicide prevention agenda, acknowledging that any suicide is an absolute tragedy, and there's a lot of work that we can do to prevent suicides. So I think that's all we've got to cover today. So if it's okay, we will leave it there and then open up to questions. I don't know, Ainsley, if you wanted to round up anything.
Thank you, ladies. I think Councillor Barney wants to say a few words.
Yeah, I just wanted to thank you for your choreography this morning in your presentation. I again found that amplified the report very, very helpfully. Just also wanted to draw members' attention to, Viv touched on the work of Jonathan Gribbing in his annual report and focusing on SMD, severe multiple disadvantage. And these are case studies that Jonathan wanted to take his report from being a paper report. He made a visual report, and we did some wonderful interviews and case studies with real residents, real people's lives, 5 people across Nottinghamshire who have interacted with the services that have been discussed this morning and the differences that they've made to their lives. If you haven't seen them, I'd encourage members to look them up, find them up. Maybe we could even pass on the links again because it does really bring to life the reality of the importance of this stuff. It takes it from being just the dry black and white stuff on the paper to the reality of the difference it makes in people's lives. I also just very briefly wanted to touch on the work of our AMP teams. Thank you so much, Claire, for taking the time to come. I think you really, really did a brilliant job describing your work this morning. Scott and I have had the enormous privilege of visiting some of our AMP teams and meeting a number of the AMP team colleagues, and I have to say the work they do is actually probably some of the most difficult work that anybody in a local authority setting gets to do. It's some of the most important as well. It touches more acutely at the heart, at the core of humanity and people's families than probably any other area. And balancing the reality of getting involved in acute mental breakdown and family members and other children, it's absolutely immense. And it's not a job that you talked about your 12-hour shifts. I mean, that's worthy of note in itself, 12-hour shifts. It's not something you can walk away and just put down. You go home, you carry this stuff, and just really phenomenal work you do. So we're fully supportive, remain fully supportive. And just also to point out that even though I've done a little bit of talking around this morning, this obviously sits very much acutely across the public health and the adult social care team. So it's much part of Scott's portfolio as it is mine. But thank you, and thank you so much, Claire, for coming and taking the time.
Yes, thank you, Councillor Barney. I was going to actually reiterate what you said, actually, and thank the team for a very good presentation, and also to Claire for coming and giving us a little bit of what the hands-on thing is, basically working on the coalface to a certain extent with the people with the problems and the issues that you have. So that was really greatly received, and I'm sure members took a lot from it. Before I open the floor, I mean the figures spoke for themselves, didn't they? How they totally increased just recently, and I suppose we've really got to recognise probably what is the difference between mental health and mental well-being as well, to a certain extent. You know where we go with this, and then identify the causes. Why is these figures going up? What are the causes, and what interventions we put in place with working partners, to try and early help with support these people before it gets too far. And I think that is something we need to do as a council, as a committee, to discuss this now. Before I open up for the debate, I'm reading the recommendations on page 20.
Yep.
Yeah. Thank you. And I'm now open the floor to debate from members, please. Mr. Kerry.
Yes, thank you, Chairman. And you partly came onto some of the stuff that I was going to talk about, and that is the importance of early intervention. And you've got all the stuff coming from all different partnerships, everybody involved in the whole thing. Do you have any evidence of where early intervention has been missed? And obviously problems can escalate, which may not have escalated should there have been a different approach to an individual in their case. And if not, is that possible? And can we sort of take a further dive into that, see if we can improve some of the comms, communications and partnership working to improve early intervention?
Melanie, yes. Go.
So I would say, Councillor Kerry, that every person that takes their own life is a prevention opportunity missed, because every person that takes their own life, every suicide is preventable. It's the approach that we take in public health, and you'll have a chance to really get into detail around that at the next select committee. And equally, I'd say the same for every mental health detention. So I think every mental health detention is an early opportunity missed, and we do work within the team and feeding back with our partners within the community trust about those missed opportunities. So yes, we do have that, and I think equally we have that at all levels. But if there's a particular you know, if it's a particular age group or area week. I mean, mental health so broad, but yes, I'd say that every one of those examples where somebody is into crisis and hasn't been supported has been a missed opportunity. And I think Claire described some of those, I think, quite well. But yeah, if there's something you wanted us to explore a little bit, let me know.
Any further questions? Councillor Pringle. Oh, sorry.
Thanks, Chair. Firstly, Claire, you know, unbelievable work. And prior to you coming, we took the time to look deeper into what your team actually does. And you should have a medal every week, every day, every minute, to be quite honest. And I think pointing out what Melanie said previously, I think I don't know how to switch off. It's an incredible thing that you do in a situation that is so inflamed at the time that you go to it. We can't thank you enough, and so please pass our thanks on to it. Just in the papers, I thought it was a really well written report that came to us, and I think that was highlighted because you highlighted the challenges and opportunities within the report, which I think we understand. I think that the staff turnover, I don't know, but we have to. If we've had a 30% increase in this, recognise that's what's coming to us. I would say it's probably more outside of that range. Then we certainly need to do something more positive than what we're doing in a different way. And I don't know what it is, but we have to look at it differently. The capacity for support housing, again, yeah, brilliant news forward. Will that be all we need? I would assume not. So that's an ongoing challenge for everybody. I'm not being politically at this out, for everybody. The Mental Health Act, the reform, which isn't coming forward, okay, but does that really impact on us? I think it's disappointing that it stopped, but are we able to maintain a standard that reflects the efforts that we're putting into to support these people? I'm assuming so. So I think the reform will probably change the directions more than give us something new that we're looking at. The report coming back in June through VIB, really looking forward to that report. Those of you know I'm the Orton representative, and we've had 7 suicides in less than 18 months, and to my knowledge, the families haven't had anything back from county. So much so that there's been a drive outside of that for their own support in creating their own groups, which is a fantastic thing to do. I'm not knocking anybody here, Scott, I'm just saying that if there's a link, then it's been fractured on 7 times. We've not responded to it. In actual fact, it's 9. We've actually lost 9 outside of the 18-month period. All men. Now, I'm not looking for anyone to be a punchbag here. I'm looking for solutions as to why this is happening, which is why Councillor Brazier is really leading on this. I'm just a bit part in this. He's really driving it forward, and Mind and Paul's Pit Stop, and all of those groups are coming together to allow people the opportunity in the community to talk. I'm not sure. I think it's valuable what's being offered, but the majority of these people that took their own lives are from good families that you would have thought would have been able to talk and say, I'm having a bad day, or I'm having a bad month, or whatever, and it hasn't happened. So I'm really looking forward to this report coming back in June, as I'm sure. In fact, I'll probably invite Lee. In fact, it might be a good thing to invite Lee to come to the meeting if he can make it. And we talked about Councillor Kerry mentioned early intervention. Are we actively engaging with schools? Because we know the difficulty in schools presently, and I think there's a crossover. I'm assuming there'll be a crossover, certainly from those that are 16 moving forward. And if we are, then let's celebrate the fact that this is what we're trying to do. And if it's not working, we need to change it to it. But yeah, back to you, Claire. I don't think I've not had anybody in my family with mental health other than me on Newcastle Get Beat. But seriously, the detail of what you do in support is incredible, absolutely incredible. And we are so lucky to have people with your genuine honesty and drive to support these people. I honestly, I can't say enough. I can't thank you enough. Thank you, Chairman.
Thank you. Scott, do you want to reply to that? And
yes, excuse me, sorry. Thank you, Chairman. Just to come back on to Councillor Pringle's closing remarks around suicide prevention, the wider agenda there, and also then the schools issue. Starting in terms of the sort of more substantive point around, say, Ollerton, for example. I think it's been no secret that I think we need to do more, to be quite frank, particularly to those that are not necessarily known to service. This is an area that I think all members will recognise that I speak from my own experiences. I've not hidden the fact that in my early 20s, I tried to take my own life. So in terms of this wider agenda, I absolutely recognise that we need to do more. When the team notify me of a death or suspected death by suicide, should I say, it's not a cliche, but I feel every single one of those. To this day, I carry those scars. So in this wider agenda, and this is why I am actually really pleased and encourage officers to bring that prevention strategy to committee. For me, this sits outside of politics. I think we all have a strong interest in public health, the well-being. You can't have good health without good mental health. In the terms of the support for those around the Ollerton locality, I'm not necessarily going to sit here and comment on each individual case, as I feel that would be wrong to do so. However, I have been guided that there has been support there. However, I will take those points away and ask officers to look into that. And as I said at full council debate, I'm quite happy to have an offline conversation, include Councillor Brazier in that as well. In the terms of the offer around schools, so the last couple of years has been the rollout of the mental health support teams across the county. Obviously, some of this was picked up in the health scrutiny last committee under Councillor Wheeler and other members present, making the point around the universality. Obviously, there has been a stronger uptake in the Newark and Sherwood district, but there are still pockets or challenges, particularly around the Bassett Law locality. I recently attended the Not Alone event that was done at Notts County Football Club, and the YMCA at Newark, which was attended by many schools from around the county and the city footprint. That's a cross piece of work between us and the city council. But I think before I hand over to officers to pick up on the other points, like I said, you members are pushing an open door. This one, this is something that's the real driver why I got into politics. I look back at my own experiences, and I think if we're all being honest, that we, to all point in our lives, have probably been affected by a death by suicide, or know someone that has been bereaved by suicide. And I can certainly think to one of my close friends and former colleagues as well in that category. So I'm going to stop there and hand over to officers. Thank you.
thank you, Councillor Carlton. That was a very heartfelt reply. Thank you for that.
Thank you, and thank you, Councillor Carlton. Councillor Carlton's covered many of the areas that I was going to cover there. But I think there's one thing around just providing that additional reassurance around the work and the leadership that the public health team are doing around the suicide prevention agenda, acknowledging many of the points that have been covered here around any suicide is a tragedy, and it is absolutely something that we should be able to try and prevent. So one of the real, we will come into this in more detail when we bring the paper back in June, but I think one of the real positive that we have got here is in Nottinghamshire we have real-time surveillance, which is a really rich data source in terms of understanding where those potential deaths by suicide may be occurring, and understanding very quickly around what action and support can be put into place. Acknowledging that public health don't necessarily deliver the exact level of support, we link with our partners around that, but there's a very strong leadership and coordination and strategic approach to suicide prevention across Nottinghamshire, and we'll be very happy to have some more discussions with you around that in this forum and elsewhere with that. So I think there's something around that. I think the other points that you raise around mental health in support in schools, I think it's also building around some of the work that we've done in terms of understanding the impact of the COVID pandemic on mental health, acknowledging that has had a significant effect on all ages, but particularly our children. And so Councillor Carlton's mentioned there in terms of some of the really good work around the mental health support in schools, but there's also that broader public health approach that we're doing in terms of the work that we're doing with schools around really making sure that we've got strong and resilient children, and that we are intervening as early as possible, because we know that if we have strong healthy children, then they hopefully turn into strong and prosperous adults as they grow. So again, I think it comes back to, if there's any particular areas that you'd be more interested to explore, then please do let us know. We can give you a little bit more detail, but there is a lot of evidence base that's been done in this area of work that we can share either in this forum or in others, if that's helpful.
Thank you. Councillor Barney.
Yeah, just briefly, I just wanted to draw Councillor Pringle's attention to a slight bit of good news, in that we have issued a tender process to provide 11 new supported living flats, which hopefully will be coming online this summer. And further to that, my understanding, Katie, is that we've also now implemented a tender document for 96 provisional places coming on. These are supported living places for people with acute mental health challenges and needs. So I hope to see those delivered this year and being a benefit to our residents.
Thank you for that update, Councillor Barney. Councillor John Dudley.
Thanks very much. Yeah, there is no health without mental health, isn't that right, Scott? It's the idiom put forward. It's a funny thing, mental health, because it turns up in so many different areas. Could be social care, could be public health, could be the A&E department, etc. And when we're trying to provide mental health, the Mental Health Trust itself is £20 million overspent. When we're trying to provide public health and work with the ICB, they're £100 million overspent. So we're providing all this against a background of significant financial challenge, and yet again against the background of an enormous increase in the presentation of people with mental health problems in all of the areas aforementioned, not least to say the amount of ADHD, the amount of autism, the amount of depression, anxiety, etc. Absolutely extraordinary. You brought me back to my days. I was a Section 12 approved GP for many, many years. Every Wednesday night in Nottingham, if you needed a GP to section somebody, it was me. So none of those decisions were easy. They were always challenging. I was always accompanied by an approved mental health worker, and none of the decisions were actually clear cut, and they were usually traumatic, either for us or for the other person. In one way or another, they were always quite traumatic. Some of us have had more experience recently, because we've had guardianship training, and I think myself and Scott and Eric, etc. So it was quite nice to get an insight into the work done by the county council through guardianships, etc. I think that was very nice to be involved in that. But I haven't had a meeting yet about the people in guardianship, but we're well informed about it. I was just going to pick up, it says here that the first point of contact for people now is their GP, but the broad basis, the provision of care in general practice has changed, and therefore you're just as likely to see an associate physician as you are an advanced nurse practitioner, as you are a mental health practitioner, as you are a GP. The entrance into general practice has a broad base now. There used to be a pinnacle where you saw the GP and you got sent out to other places. Now you're going through a broad base of provision. So although it does say GP, you could easily be finding yourself, your first point of call would actually be a mental health practitioner within the surgery. A big call out to social prescribing, which is hugely taking over in general practice. Something like 10,000 referrals in the last few years to social prescribing, showing that the basis of mental health is not in doctors' surgeries, etc. It's in the communities in which we live, and we'll come back to that in a few minutes, the importance of that. Talking therapies, anybody can walk in to a doctor's surgery and they can self-refer themselves with the number to CBT, cognitive behavioural therapy. You get 6 to 8 sessions completely free on the NHS. The biggest intervention in care since I've been a GP, how widespread it is. It is unfortunately a victim of its own success in that it's now up to 18 weeks, etc., before you can actually get to see somebody. A lot more of it's going online. And the problem with online therapy is people tell me the phone rings, I put it on speaker, and I go and make a cup of tea and a slice of toast. Engaging remotely is a very, very difficult thing, and therefore the more remote we become, the less successful, in my view, it is. In terms of mental health in itself, Viv, I think a lot of this, although here for scrutiny, is actually dealt with through the Health and Wellbeing Board and the programmes the public health is putting through there. And as Scott, we did talk about prevention, and we had a prevention JSNA. For the first time, we saw a figure of 8% as the actual relationship between suicide directly and the internet. And I think we're going to see a massive increase in that going forward. This is the first time we've actually seen it recorded as a major cause, particularly in the schools and particularly in the pressure that people are under in the schools with regard to that. So I think that's a frightening area to go forward. There is no doubt that our role through Health and Wellbeing, Viv, is to make sure that the preventative agenda stands front and foremost in our activity, the building of resilience in communities, and that involves place-based partnerships, that involves funding the partnerships to fund the communities, and the building blocks you talked about, and indeed Matt referred to in the severe multiple disadvantage, the simple important things of housing and home and education and family and friends, and building the resilience that prevents the mental illness to begin with. So that's our role going forward, Viv, is actually to champion place-based partnerships, to develop the communities that people can develop their own resilience within. An enormous challenge going forward, but there's some fantastic work being done by the County Council, not alone through the Not Alone website. And we recently put funding into schools for identifying the children of people in domestic abuse situations, to pick them out because they'd be poor performing. So I think we're doing well, but it's a massive challenge going forward, Chair.
Thank you, Councillor Dudley. I don't know if anyone wants to respond to that. It wasn't really a question, but it was a very good elaboration there. Thank you very much for that input. I've got Councillor Dark Martin.
Yeah, thank you, Chair. Yeah, I just want to go. I mean, yeah, thanks for that, John. It was very interesting, actually. I want to go back to supported living and how that's funded and where it's going, because how sustainable is that, given the increase in mental health assessments when we look at that in tandem with supported living? Because in my experience of people who committed suicide or are on the verge of, it's often a life collapse where they feel massive pressure from all directions, and usually when they've split up from a partner and they end up settee surfing, as we used to call it, around the parents or relatives who can only put up with them for so long, and that continuous pressure is there until they have a release. And of course, obviously, supported accommodation would create that temporary release of mental pressure on that person to live. And I don't know how we're funding that and how sustainable it is and what's the limit of it, because obviously, how long do people stay in them, and how does it work? I'd like a bit more of an explanation of that, because obviously when you bring your paper back about suicide prevention in June, to me that is a key element of it. Thank you.
Melanie.
I think it's important to note that I think as with Ainsley and all colleagues have said that it's a system approach to supporting people. So as a county council, we're not responsible for ensuring that people have somewhere sustainable to live, but play our part in enabling that. So there is an element of where when somebody has a social care need, eligible social care need, and then requires support from discharge, we will then have support from the community teams, and we have Iris behind us as one of those group managers who does that. And then equally, if somebody's then has some accommodation needs as part of that social care need, we've got the commissioning work that Katie outlined. But I think it's really important before Katie gives a very specific bit about our tiny role in it, to note that we work with our district and borough colleagues, all 7 of them, to enable their sufficient accommodation. And we know there isn't, so we know there's huge pressures on our colleagues about the supply of housing. And I think colleagues will describe a whole range of circumstances where housing is one of the barriers for people in either in prevention or enabling their discharge. But like I said, we do have some responsibility where there's a social care need. And Katie, would you like to just describe some of that?
Yeah. The button. I think I would start by saying that our aim would normally be to try to support people to remain in their own homes first, and looking at the care support and enablement that they need to be able to do that and maximise that, but also understanding where there might need to be supported housing in place, or supported housing with the right environment to support people. For example, someone that might have experienced a lot of self-harm, making sure that the environment of a supported accommodation is right and safe. So the work that we're doing around this is a broader housing, part of our broader housing strategy, working closely with our districts, and looking at our needs assessment for the types of environments that we need going forwards, and then specifying that, working together with districts to pull that work together, and therefore encouraging developers to come and build or create or change things that they might already have to be able to provide us with that accommodation. So a lot of work with external developers as well. Some of our work going forwards might be where we look at assets that the county council has that we might be able to repurpose in that way. And I know that there has been a history of some of that, and there has in the children's side as well.
Thank you. Councillor Barney.
Yeah, just to again bring our own context, Scott, and my own context to this, and just some of the early intervention that we have with our contract with Framework and the housing provider with Framework. Again, do incredible work every single day. Scott and I have been privileged to visit some of the facilities that Framework provide that are funded through the public health grant here at Notts County Council, and I have to say it's been quite eye-opening to me visiting those centres, because there are people in there who it's a first line of defence, somewhere to go in immediate crisis, with acute mental health issues, with drug and alcohol related issues, but also people who just find themselves in difficult, hard times. And there was on one of these occasions, one of these visits, it was brought acutely home to me just how vital these lifeline services are. There was actually somebody in there who'd gone to the same school as me, grown up in the same community as me, and it'd be the last person in the world you ever would imagine would need those frontline services, and they were so over the moon and so grateful to be there. It was deeply, deeply humbling. So I just wanted to bring that personal reflection as well in the work we do.
Thank you for that. Councillor Creamer.
Thank you, Chair. Just start off by saying that as a substitute member, thanks for that presentation. I've actually learned a lot. I didn't realise just how quite intense the actual subject was of mental health. And Councillor Barney's partly answered my questions, because I'm going to ask about the 96 units, which apparently by this year. But the second part of that is, will that actually be enough going forward? Will there have to be more units in the future? So, as everybody's already said, that the pressure is actually increasing. So I'm just wondering how far we go into the future and how many units will be required eventually.
Kate.
Hi, yes, it's a really positive step forward that we've got those 96 units starting to, the mobilisation work to work towards those. So will that be enough is the crucial question. We need to be really clear about the support to keep people in their own homes, and also the environments that we might need alongside that. So the broader work is our housing strategy. So as a county council, doing our own strategic needs assessment, so projecting how many more people we think are coming through with specific types of needs, and also working with the district councils on their strategic needs assessments and bringing those things together so that we can start to scope out what we think the need will be, geographically where we think we're going to need some of that, and therefore continuing to have an evolving plan to work towards it.
Councillor Bailey.
Thank you very much, Chairman. Possibly for Councillor Pringle's information as well, at the health scrutiny meeting we did quite a bit of in-depth looking into children's mental health and that early intervention. So I think it's definitely a big issue that we need to be looking at, and I'm glad that it's not this committee that's looking at it, other committees are looking at it. So I suppose my question is there any public list or section of information that looks into almost the demographics of who are dealing with these mental health teams? So obviously men's mental health is a big issue, not least because of the suicidal rates among men, among one of the highest. I think that suicidal prevention strategy that's coming forward would be very interesting. And obviously in terms of locations and socio-demographics as well, I think it's really important that we're almost taking that into consideration when we're looking at early intervention. Are we intervening in the right place, and can we do better in other areas? And in terms of groups as well, so I know it was mentioned that you do consult with groups such as Mind, as well as others. Is there any list of other groups that you consult with? So, for example, I know that In Sam's Name does excellent work when it comes to mental health, and I believe it's expanding across Notts, so I believe it's works up. I believe Alton has a branch now. So I just suppose, in terms of who you're talking to, in terms of your social groups, is there a list of sorts that that's out there that others potentially have a look at and go, oh, well, you're not really talking to these people? It's just in terms of community engagement, getting in touch with them. And I suppose the other one, which isn't really a question but a point, as a challenge in terms of workforce. I mean, I think I've not sat through a committee where workforce has not been an issue, no matter where. So obviously got it in hospital, we've also got it in this department, pretty much across the council. Workforce always appears to be a problem. So it's almost looking in advance, if workforce is a challenge, other ways of doing it which can negate that challenge almost. Can we address that challenge? Because workforce is a problem, I feel, that's never going to go away this rate. So if at every report almost we go, workforce is a problem, it's almost, are we ignoring the other problems that we could be solving through creative thinking? Thank you very much, Chair.
Yes, baby. Well, Katie also, yes, I did.
I was just going to come in on the point about prevention and the fact that we have got organisations on the ground that are doing some really good work. And I think just going back to the point made by Councillor Doddy about how we're working with and through our place-based partnerships is really important in that. And I think as we start to further develop our adult social care prevention strategy, thinking about how we work with those place-based partnerships, and a lot of the groups, communities, faith-based sector, voluntary sector, special organisations that do some really good work, and how we can be a really good alongside-er to that. So we need to think as a whole system of partners, some of the funding that we are giving and how to make that work in the best way on the ground for organisations that are doing some really, really good work in a way, and mobilising volunteers and support in a way that the statutory sector couldn't in that space. So just holding that thought and signalling that we've got that in our sights in terms of thinking through that element of the prevention strategy.
Thank you. Thank you for your question, Councillor Bailey. So in relation to needs, we did bring a suicide needs assessment to the Joint Health and Wellbeing Board back in February time. So we do have a clearer picture in relation to the needs of our population. And you're quite right. We know that males are 3 times more likely to die by suicides than females, but we also understand some of the nuances under that a bit better than we did. In relation to where people go to, again, a really important question for us. So at the moment, under the Nottinghamshire County Council website, we have links to various organisations, but Councillor Carlton mentioned about Knots Alone. Currently, that's available for children and young people, but that web service is being extended out to the adult population as well in the summer, because you've identified a clear need in relation to our populations. We do run a suicide prevention stakeholder network from the county that people are, we're more than willing for people to be involved with that, so that provides people with an opportunity to link through. And coming up in the summer, late spring, early summer this year, we will have some community grants that will be available for groups that work with people who are at risk of suicide as well. So there are various things that are in train. Thank you.
Thank you. Councillor Cole.
Thank you, Chairman, and thank you, Kath, for that. Just to sort of build back onto to you, Councillor Bailey. Really good questions. The other piece in there for me is the 66 councillors that we have in this organisation. We are all key stakeholders within each of our own divisions, and that probably sometimes sounds a little bit cliche. Public Health last year did offer some member training sessions. They weren't necessarily well attended, but for those that did, they equally got to share some of their own experiences, but also received some valuable training. I know in discharging my duties as a county council member, I've had members of the public engage me in crisis, and that just gave me that sort of extra reassurance of where I could direct them to. I've recently asked officers to put that background, and I would use this platform to encourage all members to take part in that training when it comes forward.
Thank you. Well, thank you. Councillor Williamson.
Thank you, Chair. The report states in paragraph 5 that the first point of contact with services should be the GP. In my division, in Brinsley and Greasley, residents can wait weeks for an appointment at Eastwood Primary Care Centre, and even on the phone, you can be on the phone 45 minutes just waiting to speak to somebody. So I appreciate that there's alternative ways for residents to seek help, like the 24-hour helpline, but residents in crisis are not always armed with that information. Do you think that better access to GPs will help with the mental health needs of residents? Thank you.
I think access to all services really to help. Melanie, you'd like to take that one on?
So access to primary care and general practice, I agree, is a concern across the county for many of our residents, and it is something that Councillor Wheeler has just left, but Health Scrutiny Committee have been examining this for some time, so that's the place to have a look at that. In terms of our own access, I think as Councillor Carter's described, the Not Alone provision and some of the methods that Viv and Kath and indeed Ainsley set out in the presentation, the ways that as a county council we try to ensure that people have all of that information to them, but the routing into whether it's crisis support or other forms of mental health services through that primary care route, but we agree it's not consistent across Nottinghamshire all of the time.
Thank you. So I think Melanie's covered a lot of the points that I was going to cover. I suppose there is something around we always want to support people to have a positive emotional health and well-being and mental health. So we will always be looking at additional ways that we can increase our reach in terms of that, and some of that might be around the access point of view in terms of making sure that people are aware of when they need those services, do they know where to go, and that's one point. But I think there is something around how do we build those strong communities? How do we make sure people have good work, good housing, good support around them to reduce the likelihood that they will need to access those services? So for me, I suppose it's a two-pronged approach in terms of how we're doing that preventative work to really support our population to have the best emotional health and well-being they can. But then if they do need the services, it's being really clear around knowing where to go and how to get the timely access that we can. And then Melody's touched around how Scrutiny are doing a lot of work around general practice, but also building on what Councillor Doddy said around that general practice is not just the GP now, and it's about how we can support our communities to understand that the offer is slightly different, and there's more work that we can potentially do around looking like that, but working with our health colleagues around that space.
Thank you.
Chair, just a point of clarification on that. I was just going to clarify that a lot of these services now are self-referral services, so you don't even need to come to the GP, but you're quite right that people don't necessarily know that they can self-refer, so there's a lot of potential work through public health, etc., that we could do to let them know that, but you can self-refer for CBT through the talking therapies, etc. You can self-refer to CAMS. You can self-refer to so many places now, but people's default position has never changed because their mindset hasn't been changed. Perhaps that is something that we could sort of look at disseminating better. Thank you.
Thank you, Councillor Doddy. Councillor Pringle, last question.
Thanks for letting me come back, Chair. It's just a quick one for Viv and Kat, really, and Scott. Obviously, I'm sure you'll be aware of the attention in Alton with the BBC and the ITV. There's regular interviews going out on stations. The important part of Paul's pit stop and Sam's name, which is from Workshop now in Allerton, led by Councillor Brazier. I'd be really interested, especially if you're going to deliver something in June, to actively engage with these people, to bring something back in June that is representative of them, because there's a little bit of confusion as to what we deliver and what's available. Clarity on that would be so good for everybody, to be quite honest. Thank you, Chair. And just to say, I'm still waiting to go for a pint with Michael, mate, or we'd arrange that. So.
No, thank you, Councillor Pringle, particularly on your closing remarks. On the sort of more substantive part, I said I will repeat again. Let's see, me and have that conversation. We can, officers have well briefed in terms of some of the media coverage, social media coverage as well, the campaign in more general terms. And I did see the other night the piece on East Midlands News with the parents of Sam. For anyone that watched it, you can't fail to be moved by that. So offline conversation, I think, from this, and let's move forward on it.
Thank you, members. That's been a very, very good debate on a subject I think it's touched a lot of people. And from the figures, it's something that's increased and it's something we need to be probably looking at and helping people out there. I mean, I think Councillor Pringle pointed out, it's good to talk, and I think that's a lot of the thing is identifying the people that have got problems and issues and giving them a pathway to talk to people to help them with the mental health and their abilities. Because we all know one suicide is one too many, and that is something we can prevent one. Then, but that is a fantastic outcome that we can do. So I think there's a lot of work going on out there. I think there's a lot more work to do, but I think it also identify to the residents and the public, if you think somebody needs help, there is help out there. Let's point them in the right direction to get it. Martin, you've got something up to do.
Yeah, obviously we've got the suicide prevention strategy coming in June. I think that will cover a lot of the issues that were raised by members. But just a few other things which I hope I've got down correctly. The information on the demographics of those accessing mental health services provided through the council will be circulated to members of the committee. The adult mental health services and support delivered or commissioned by the Adult Social Care and Public Health Department be considered for inclusion in the 24-25 work programme. And I think finally, I think you'd probably agree that the work of the council's approved mental health professionals be commended.
Okay, members happy with that? Okay, all those in favour? Okay, that's unanimous. Thank you very much. We now move on to what I think is a bit of good news report, the discharge to access progress report. Councillor Bond, would you like to introduce it, please?
Thank you, Chairman. The report is actually in Melanie's name, but just to say before Melanie speaks on this, a huge amount of work's been done now over many years, actually, and I think that work is playing fruition. I'm incredibly proud, actually, of the work that's been achieved by our team here under the leadership of Melanie, and also for the incredible support and the work of our colleagues in the NHS and the ICB. This really is noteworthy, and I think actually is a national front runner in terms of the success of the work to date. But I will let Melanie amplify more, warts and all. Thank you, Melanie.
So Subat is going to walk us through the report and the presentation, but I think just wanted to add that whilst hospital discharge is quite a small part of what adult social care does, it's an important part that we do really in our role as system leaders, because being a good partner and good colleague to our health partners is really important. So like I say, it's kind of small volume but important for those reasons, and I think it's really pleasing that the work on discharge to assess and the transfer of care hubs that Sue will walk us through has been recognised nationally as good practice, and it's really pleasing that's been noted. And I think our hospital partners would have been in a huge amount more difficulty over the winter with the junior doctor strikes and other pressures had we not had this work being so successful. So I think that's all I'm going to add, and Sue will just talk you through the report, and we'll be pleased to answer any questions about the detail.
Thank you very much. Before I open it up to the debate, I will move the recommendations on page 41. A second.
Oh, yeah, I'll second that.
Thank you. Members? The members like Councillor Pringle?
Just thanks for the report, Sue. Just on 24 bullet point 3, with all the positivity that's within the report, we'll then come on to financial risk in the ICB and the impact of that. We already know through council the difficulty that ICB have with finances presently. So I think that's a concern for us. And I'm also understanding the impact negatively on social care because of the lack of funding. Again, everything's about bloody money and not people. And we need to find a way to change that if we're to provide this. They were just the 2 points that I sort of positive report. I then thought, oh no, hang on a minute, here we are again. So.
Who wants to take?
So I'll take this one, yeah. So I think it was important to flag it up. However, as the report says, we're working really closely with our partners, and we must recognise that a couple of years ago the ICB did invest in extra community capacity, extra reablement. That's been really helpful. Also, we've had the discharge grant with the sum allocated for social care and the sum allocated for health, but which we work together to plan. And that the report sets out how we've used that for extra capacity in posts, etc., to support us in the work. So in many ways our system is in a better position than we've been for quite a while as we recruit up to that. I think it's the key bit is that mature partnership continues to have those discussions, and as we move to be less reliant on putting people into beds out of hospital and maybe close some of those, that we're making sure that there is sufficient capacity in the system, and along with any of our other joint funding arrangements. So it's one to flag there, but I think we've seen quite a change, and our partners have been working well today.
Councillor Adair.
Yes, Chairman. I remember this about 12, 13, 14 years ago being a similar question, and implement discharge and the assess model. In fact, I think the County Council wrote a computer programme to help between the social services and the NHS to enable them to somehow make it better. But when I still talk to some of the residents and say, oh, we're in hospital and we can't get home at the weekend, and the reason is because there's no package, whatever that means, and also that the pharmacist hasn't done the medicals that they're supposed to take home with me, and it still seems to reoccur. What I was listening to 12 to 13, 14 years ago, there might be a greater volume of it now, but I don't think, as far as the problem is concerned, it hasn't gone away, and I don't know, and I probably won't live for another 14 years, but if I live for another 14 years, I think I'll still be reading something similar, unless there's some dramatic change somewhere, and where does that come from?
Sue?
Yes, I mean, it's a really good point, and the report points out that despite all the improvement work today, we've still got more people waiting in hospital longer than they should have done. But what's been quite a game changer is that we've built on that computer program and we've developed it, and we've now got what's called locally as one version of the truth data. So everybody in the hospitals can see exactly where each person is, which team they're with, and who they're waiting for. And we're starting to work through what some of the biggest delays are. So there's much greater clarity on where those blocks are, so we know where to focus. And recently we know that one of the greatest delays is actually in getting the referrals to the hub for social care to wait for them. So actually waiting for reablement and home care is not a significant issue. There's more we can do. Sometimes we haven't got it in the right place at the right time, but it's not causing the delays that it has in the past, despite there still being that national media narrative. There's no one solution to solving hospital discharge. The delays are for many reasons. The person who decides to go to A&E rather than to their GP or pharmacy, the decision to then admit that person, the decision then to treat them in hospital rather than send them home for the community, as well as all that bit about planning for people that do need support in terms of getting their support and medication and transport all lined up. So it's really important that this data now shows where the numbers of people working, and over time we're working through the areas that are the biggest problem. So when we had our national insurance meeting, we've had a letter since. We got really good feedback. They recognise that we aren't where we need to be yet, but they think we've got the blocks in place and the partnership that we can really build on that and make significant improvements over the next year, because I think everybody acknowledges that we've still got things like the ambulance delays, the ambulance handovers, that we're really all working hard together on to resolve.
Yes. Oh, sorry, Councillor Owen.
Following on from that, the report itself talks in terms of percentages each time. We don't actually get any hard figures unless I've missed it amongst all the paperwork that we've had circulated to us. And from what you say, there are a variety of reasons why hospital discharge is delayed, and surely that is what we should be scrutinising as a committee, the various reasons why the delays take place. It seemed from what you're saying that you're a bit of a council of despair, because it appears that from what Councillor Adair has said, things are not getting significantly better. Now that may be wrong. I may be wrong in saying that, but that's the sort of data and the sort of detail that we would need to do an effective scrutiny. And that, to my mind, is what this committee should be all about, identifying the areas where delays are taking place and seeing what can be done from a county council perspective to improve it. And even if from a county council perspective we cannot improve it, at least we can set down the causes and pass them on to the relevant authorities.
Thank you. Take that one, Sue. Always.
Yes, I'm happy to take that. So the position is improving, but because we've had even more people turning up at the hospitals with more severe conditions, it's not. We've still got too many people in hospital, if that makes sense. So I did consider putting some of the graphs in, but I felt that might be quite a high level of detail, so I summarised it to say that we are meeting the trajectories that we've set. So there's a steady trajectory to reduce the number of people who could go home, an improvement trajectory, and at the moment we're on track for that. But I can certainly bring a little bit more detail around that and some more of the detailed information, or share that after this committee if that's helpful.
Thank you, Sue. Thank you. Councillor Martin.
Yeah, I think Councillor Adair pointed it out earlier on, but the system that they implemented 10 years ago has worked, and I think it is working. I think the other thing is the volume of people that are going through the system as well as that. You know, there are more people going through the system now than there were 10 years ago. The other issue is, of course, is your turnaround from people having the ability to be released to releasing is about 5.6 days. I've seen it somewhere in here, you know, but that is not always the fault of the county council's social workers, and it's more about the communication from the NHS to them, actually acknowledging when those patients are ready for release. Pharmacy used to be a big issue at weekends. It was shut all the time, and I think I'm reliably informed now that at Kingsmill it stays open till 12 o'clock on a Saturday. But you know, so that was a big issue at one time. The other issue is of course, is when we talk about readmissions and the package you're on about, Reg, was called the Start Package, where they had 6 weeks and they had diminishing care administered at home, which was the best place, depending if that's where they went. Now we've moved on to the pathway system. So my question, and this really is a result of COVID, because obviously COVID accelerated and changed the way that the social care workers are managing discharge to assess programs. What I would like to know is the readmission rate, has that dropped? Because obviously, as a result of changing the pathways, because this is a more manicured, defined pathway than it was prior, where it was like a blanket system. This is more tailor-made, if you like, to each individual patient that's coming out. So government statistics are showing nationally that readmissions are higher, but I wondered if in Nottinghamshire they would be lower. You might not have the figures today, but it'd be interesting to know if the end result of the changes from what you've implemented, if that's having a beneficial impact on readmissions, because obviously we know that readmissions are a major problem because they go back in and they end up going through the whole process in the hospital again, and bed blocking is a problem at the other end. So that would be my biggest question. Has the system change made any difference to that? Thank you. Oh, and the other thing is the recruitment of staff. That's another big issue as well, isn't it? On your occupational therapist side, how are you managing with, you know, employing new staff and retaining existing? Because that's always another issue which has an impact on discharge to assess. Thank you.
Thank you, Melanie.
I wanted just to comment on Councillor Owen's query, so just to give some reassurance. So what we have is a live dashboard across each of the 3 hospital sites that shows how many people are waiting for adult social care every day, and then what they're waiting for and how long they've been waiting. So we didn't bring that here, but we could easily do that, and we could either do that on what a day looks like or what an average week looks like. So that data is freely available, and like I say, we look at that every day. But just sort of as a snapshot, there's probably about 500 people across Nottinghamshire waiting to leave hospital, and then those are responsible for adult social care ranges between 40 and 50 a day. And out of those, most of those go within the same day or the next day. So that's a sort of average performance, but there is some variation out of that depending on individual circumstances. And the most common reason that people are waiting for is this reference that Sue said. So it'd be that maybe that I'm in a rural part of Bassetlaw, and it just takes a bit longer to mobilise that package of care, or it might be that I've been neglecting myself and the house needs to be cleaned because it's not fit for me to go back. So that's sort of some of the common reasons. So we do have that information. So if we can give that as a supplementary or come back to a further committee, whatever chair you think's most appropriate. And then Sue, I wonder if you could just pick up the issues about workforce within discharge to assess that Councillor Martin also raised. Oh, sorry, readmission rates. So nationally they have gone up. So we wouldn't look at that from an adult social care perspective. What we do have a look at is sustainability of support. So certainly what we've found within our reablement services is that it's quite difficult because of complexity of need to support somebody with their health concerns. We don't track readmissions per se.
Thank you. And the report does reference that as a system we want to do more work about avoiding hospital admissions, which includes readmissions, and some of the examples of how we've used technology illustrate how important that can be. So that's one of our objectives for this next year, is to scope out that piece of work and look at what we need to do. And my example would be is when we look at the greatest reason for admission to both Queen's Medical Hospital and Kingsmill is urinary tract infections. That is so we know that using things like tech and other things can identify that earlier and actually resolve it without the need for an admission. And actually, if we do better work on hydration across all our services, that would prevent the infection arising at all. So just to pick up, that's an area of work that will be on our radar for next year. In terms of workforce, registered social workers, qualified occupational therapists remains one of our most difficult areas. However, we are seeing a slowly increasing our capacity because we've got a huge range of different campaigns and different ways that we're looking to improve that, including we've significantly increased our number of apprenticeships in the council around those posts. Reablement workers, home care workers, unqualified social workers. We've again done different types of campaigns that are more value-based recruitment and aimed at people coming into those areas, and also promoted how through the apprenticeship schemes people can have a career pathway. So for those areas we're doing quite well. As Melanie says, there's always an issue with very rural areas, and we've done some specific recruitment. People might have seen Shining Stars that we did around in Bassetlaw. So it's not as good as we want it to be, but we're working really hard on it, and we're seeing gradually incremental improvement.
Thank you. Councillor Dudley.
Thanks very much, Chair. I love this type of work. I love the work agency to create the holy grail of limiting the amount of time anybody spends in a hospital to the absolute necessity areas. I remember presentations at hospitals where they have green days and red days, and a green day when you're in hospital and something positive actually happens, and red days when you sat there and absolutely nothing happens, so it's an actual wasted day. It's a great example of system by default at the moment, how we're working together for everybody's interest to get people home as early as possible, and that sort of came to the fore, I suppose, over the black winters and things, when people were getting discharged to care hotels, where hotels were being taken over, and where nursing homes were being taken over, and residential homes were being taken over. And when Kingsmill took over the bottom floor of a residential home up beside the hospital and put their own staff into it and discharged people to it, it was still 50% cheaper than having those people in the hospital. Just moving them out to a floor, putting their own staff in at the same pay, reduced the care by 50%. Has to be the untapped area of actually helping to balance the incredible difficult financial challenges around those who get discharged and readmitted. So they're called failed discharges. 24 or 48 hours after discharge you get readmitted. It's not social care that's actually responsible. The hospitals get judged by CQC and government in terms of the funding if their failure to discharge or safely discharge people actually goes above a certain target. So it's not really something that comes back to the council, it goes directly to the hospitals themselves. But overall, I think some of the work around virtual wards, some of the work around technology and picking up people with possible urine infections before they ever get admitted to hospital is at its peak. It's something that we should be incredibly proud of and will serve us well going into the next winter, and hopefully we can just build upon it. But I think it's great.
Thank you, Councillor Dolly. No other questions. Yeah, we used to have what we call convalescence homes at one time, didn't we? It was like a halfway house for people leaving to the
community hospital.
Yeah, because I have just actually experienced this myself, because I've just had an elderly relative who's been discharged from hospital last Saturday. We didn't know. We're expecting to come out about the following few days later. I got a phone call Saturday morning, because I'm responsible for his health well-being. And he was coming home as a single man on his own. We were able to facilitate him, but I think a lot of people wouldn't be that quick now. And now I've got another phone call saying the transport wasn't there, and then another one again about the pharmacy and medication. But it came up, but I have to say the package he's received since he's been there has been absolutely fantastic, and every need has been dealt with, this, that, and the other. But it was a little bit out the blue. So I think there are a few little bits, bottlenecks and snagging bits that need to just be ironed out on the process. But I think what we're doing is absolutely fantastic and the right thing to do. Because I mean, this relative now, he's at home. His mobility's not great, but he's happy as Larry. He's a lot happier was in the hospital, and he's a lot healthier and mentally a lot stronger for it. But I'd say there was a few hiccups along the way to get him there, which we as a family were able to cope with. But I think it's something that Councillor Dunn came up. We need to probably just scrutinise these bottlenecks a little bit more, where the issues lie, to make it a little bit more smooth on the discharge. Because I think the actual process is brilliant now. To get people home out of hospital is only a good thing, but we just need to make it a smooth transition as well as we can. Right, Martin, do you want to read out the recommendations?
Just a couple of things. Might be a third one. The data on the time being taken discharged from hospital will be circulated to members of the committee. Information on the number of people in hospital waiting for adult social care services also be circulated to members of the committee. The other one was really, because obviously in the report you'll see a lot of the not issues, but situation around this is a health issue. That it's like, if you want to look at that in more detail, it may be a point that there's like a joint work with the health scrutiny committee, because a lot of these issues highlighted in the report, they're not something that the council has control of, so there might be the opportunity to do some work. So probably what I'd say that the chairman has a discussion with the chairman of the health scrutiny committee, consider whether there's any possibility of some joint work on this.
Okay. All in favour of those recommendations? Thank you. That's unanimous. Thank you very much. And we'll move on to agenda item 7, adult social care, public health performance risks, and the financial position Q3. And again, ask Councillor Barney to introduce this, please.
Thank you, Chairman. So this absolutely sits between Scott and myself in terms of responsibility. First thing I'd like to just point out is, and it's been pointed out to me by other departments of this council, the quality of the risk report that our department produces, I think, is the envy of other departments in terms of its transparency and the data that we present. I think it gives a very open book and a very open statement of the health of adult social care and public health, and I hope that feeling is reciprocated in the room. You'll see in terms of adult social care, this data is actually we're a little bit behind here because this is December it reports to. Clearly we've moved forward. At that point we were projecting a 2 million overspend in adult social care on our year end. However, I think Mel will confirm that we're hoping to have closed that gap and be providing a balanced budget by the point we hit year end, so that's good news. I think the greatest challenge continues to be in living well, with the overspends being occurred in the placement cost, which we see ever increasing demands and ever increasing rises, inflationary demands and just ever expanding costs in that area. But that's being offset by use of grants and by some micromanagement of finances within the department. I'm sure Mel will allude more. And you'll also, relating to the last item, be delighted to see that for the period up until December 2023, the days to discharge in hospitals had also reduced, in light again of the brilliant work that's been done over several years by our department. So Mel, you can pick through, and Scott, I'm sure if you've got anything to say, feel free as well. But hand over to you, Mel.
Okay, I don't have the link for the meeting, so I can't share the slides, but I'm sorry about everybody, but if you'd like the slides to be shared, I'm sure Martin can support, but they are also in the pack, so I'll just talk. So within the report, there's the written report. There's some 15 stories of difference that celebrate the impact that public health and adult social care have had on individual lives. So I really encourage you to have a look at those stories, because hopefully it brings to life some of the things that we do as the department. But in the slide pack, we gave some particular outcomes, and the story that I really want to share is within our learning disability complex care service. This is where we support people, adults with a learning disability, coming home from hospital. So many of them have been there for some 30 or 40 years. Some it's a much shorter time, but in the main it's at least a 4-year admission that somebody's experienced in hospital. And this is one of the areas that I'm hoping that Mental Health Act reform will change, actually, because there's some really important areas where Mental Health Act reform does have an impact on Nottinghamshire's residents. But I think this is a beautiful story, because we worked with our partners in health to develop some supported accommodation. They were very bespoke in the way that Katie described, in terms of being anti-ligature, being able to be under observation and supervision without having somebody being next to you, so without some direct physical intervention. So particularly important for people experiencing autism. And the people that we supported to move there had Christmas at home with their families, which may sound like a sort of a something that you think, well, isn't that something that everybody has? But it isn't. So I really wanted to start with that as a story, because I think it's an important outcome. So getting a bit more onto some of our technical performance. So we structure in adult social care our performance themes with the Making It Real approach in the local account. So Councillor Barney presented the local account to Cabinet. I can't remember when it was, Matt, but it was this year. And we described about how we're describing our adult social care performance in a way that people with lived experience want us to. So one of the themes is wellbeing and independence. So I think Sue and Matt have already touched on hospital discharge. So really I wanted to describe some of the work we're doing to improve people's outcomes under safeguarding. So safeguarding here is about our own responsibility. So you've heard at Select Committee before, the chair of the Adult Safeguarding Board talk about the partnership arrangements, but this is very much about our own MASH and our own staff, about how they respond to achieving outcomes for people. And we've been concerned that our performance has been a bit sticky, so it's relatively good performance in around 80% in terms of achieving an outcome for people, but really we should be making sure that everybody we're working with has an outcome after intervention, or you kind of would say, well, what's the point of us working with somebody if we're not achieving that? So we've had some really focused work on improving that, and that's been about enabling people to use the system properly. So some of it is about our processes not being very slick for people, so that's been a part of it, but also about making sure that we give good guidance, support and training. So that's one of the things to pick out there. Really pleased about our progress with long-term reviews. So we have really strong performance here, the best in East Midlands actually around our performance on long-term reviews. So review is a very basic entitlement in the Care Act. So it's where you at least once a year have your circumstances reviewed to make sure you're safe, that the services you receive are meeting your outcomes. So like I say, it's a very basic entitlement. As a department, we target reviews. Some people have had multiple reviews. So in the way that Sue and Ainsley have described, when somebody's circumstances are unstable, when they need to change. Thank you. When the needs are changing, we would review multiple times. But this work is about the long-term reviews, people that have received a service, maybe being supported in a care home. So we've had a real effort as a department to make sure we're improving the performance there, and you can see the impact on that. I'll sort of whiz down now through flexible and integrated care and support, and I want to really touch on the work of the carers strategy. So carer strategy was agreed by Cabinet last year. It's a piece of work I'm really proud of. So it's system-wide work. We work along with the Integrated Care Board and the City Council on this, as well as having a very focused piece of action ourselves. And it's also part of the ADAS campaign. So we were part of the carers campaign that we signed up to as an organisation. So nationally, there's been a social care drive about the need of carers. So this has been co-produced. It's taken a very long time because of the way that you have to support people to be heard and to work closely with them. That takes time, actually. So that's why it's been a long time in progressing it through. And we're really pleased about that, particularly for our carers we've heard through the big conversation, the carer strategy, that accessing short breaks is the thing that's most important to them, alongside information, advice and guidance. So you'll see in the local account how those two areas are a priority for adult social care going forward. So that's where we're really focusing the time around short breaks. I think we've touched upon supported accommodation in earlier conversations, but just to draw members' attention to that diagram that sets out the whole of our supported accommodation, given there were a few questions that arose about accommodation housing in the previous conversation. Workforce, again, we've talked about that. We a number of sessions in committee today and the work we're doing about internal workforce and external workforce. So I think just as a reminder, we have 25,000 people that work in adult social care. It's 26,000 across health and adult social care if you add in public health commission services. So that focus on our workforce feeling well supported, that their well-being is respected, they've got good supervision and they're trained is really important. So we're really pleased that we're able to do that through the mental health first aid work for external care providers. And I think that fits really neatly on some of those conversations we've been having about how concerned we are about the impact of COVID on people's mental health and how mental health is a growing issue. So just to draw your attention to that. Public health performance, so the recommissioning of the integrated sexual health service is finally drawing to a conclusion. So hopefully, Viv, we've moderated, haven't we, because that was through February, and we'll be able to notify colleagues of a successful bidder soon. And then I think you'll be aware as a committee about the work we're doing now in partnership with Notts Healthcare, because we know there are concerns about that the Secretary of State has about the quality of service there. So the way that we partner, either through the Healthy Families programme or whether it's through some of our links in adult mental health, as you've heard Ainsley describe, I think we're looking really to make sure that we achieve those good outcomes for residents on an ongoing basis. The slide I've included about risk, we call it vital signs. That gives members a bit of a heads up as to the areas where we have concern. So I'm really pleased about the work done on home care. So we don't have any delays in hospital. What we think is because of home care capacity. We've worked really hard on market sustainability. So Councillor Barney took several papers to Cabinet last year about the investment of our market sustainability grants and how we're focusing on home care and reablement in the way that Sue's described. And we've really seen that market stabilise, and that's quite an incredible achievement both for ourselves and our partners in the Care Association and home care providers. So it's been a big effort. We are still concerned about the quality of care in our care homes. So we're seeing now regular provider failure in the care home market to an extent that we've never seen before. And that's for a range of issues. Sometimes it's about their own ability to recruit staff. Sometimes it's about a key person like the registered manager leaving. Sometimes it's about financial sustainability. So the team is experiencing quite a degree of risk around care quality. So that's an ongoing concern that we have there. And then financial performance, you have the departmental performance in the pack, as well as public health financial performance about how we're using the grant. And Councillor Carlton may want to comment on some of the work he's doing, looking at the investing of reserves in a moment. But just departmentally, as Councillor Barney described, we're expecting to finish the end of the year with a balanced position as a department, which I think has been incredible work given the demand that we've had. And it is correct that on care packages we are spending more than our budgeted amount, and we are making mitigations in the other areas of the budget to manage that, to avoid the risk to the council. And particularly what's driving our care package spend is the cost per person has gone up. Some of that is about inflation in the market, but some of that we're seeing about half of that is because of complexity of need. So we're spending on more care per person, as well as the cost of that care being more per person, if you can get the nuancing between those two positions. But I think that's all I wanted to say from an officer perspective. And I don't know, Councillor Carlton, if you wanted to comment on the public health grant reserve strategy.
Yeah, thank you, Mel. And let's go back a few days actually. In the terms of the full council debate that I spoke in, outlined forthcoming priorities for the year and beyond, particularly in line with the current MTFS as it stands. Obviously, page 59 of your packs makes reference to the £9.6 million public health grant reserves available as at the end of this financial year. Just to be absolutely clear, there were a number of proposals within the budget document, particularly in relation to the rollout of family safeguarding teams from their public health contribution of just over £3.1 million into the year 27-28, then recurrent investment for speech and language therapy for children and young people of £2 million. So in the terms of that £9.6 million, over the next 4 years, you can see that that is coming down pretty quickly. There were some other points that I outlined to full council, but with doing some little quick mathematics on the spot, there's approximately £4 million left over the next 4 years. I actually have it in front of me now. In the terms of where the priority areas will be. So obviously the papers again do make reference to the severe multiple disadvantage, which I said it would be the guiding light moving forward. Domestic abuse, mental ill health, drug and substance use, etc., etc. And part of that will also include this morning's debate, particularly around suicide prevention. Thank you.
Thank you very much. I move the recommendations on page 77. Seconded. I open the debate up to members. Yes, Councillor Dolly.
Thanks very much. There's very few departments got it £9 million in reserve, so it's fantastic in that respect. I wanted to concentrate just on a couple of little areas, particularly around public health, and there is no doubt that since 1948 we've never had so much syphilis, untreatable gonorrhea resistant to antibiotics, and a sexual health explosion post-COVID. I know we're recommissioning the services. We're hugely at risk as a university town, one of the top 10 of the explosion of that. A number of places are offering things such as regular testing for at-risk populations and groups, etc. Are we happy that we have the right level of commissioning, bearing in mind that the less testing you do, the less disease you seem to have? But the contradiction to that is that you're not picking up disease, and whether or not some of the reserves may need to be diverted into what is, without a shadow of a doubt, a sexually transmitted disease explosion in the country. The other thing I wanted to do is probably around BIV, is to ask, have we made sufficient provision for the likelihood of a measles outbreak, that there's the East Midlands next in line to the Midlands, which has had hundreds of cases in 1 month compared with normally 100 cases per year. The seriousness, the infectivity of measles, 15 times that of COVID, from an R factor point of view, hugely down to the decline in vaccination rates. And again, very much a public health issue. How have we managed to drift down to the mid-80s for vaccination rates for MMR and vaccinations in general? Where are the problems? Are we identifying them? Travellers groups, immigrants, various European populations, Andrew Wakeman's autism and MMR. There's a huge challenge with vaccinations at the present moment. Although we don't administer them as the county council, it's a public health responsibility, and we're judged through public health outcome frameworks on a quarterly basis on how well we're doing in comparison to other places. And I do think that if measles is a deadly disease, it's in the Midlands at the moment. It's heading towards the East Midlands, and how well are we prepared for that? We have a lot of experience in dealing with epidemics and pandemics with COVID. What have we got lined up? Are we keeping some reserves to deal with episodes such as that, etc.? And the last thing that I was particularly interested in was the 2 examples of Bovidal in detox. And they're shown 2 really successful examples of Bovidox in detox, which is an injectable form of buprenorphine, but it's about 30 or 40 times as expensive. It costs hundreds and hundreds and hundreds of pounds per week, as opposed to pounds for methadone, etc. But when I was looking into it, I couldn't find, although these were two successes, I could find no useful comparable figures to suggest it was a more successful form of intervention in detoxification than I could the cheapest form of methadone. But we're using more of it and we're funding more of it, etc. So it could be that we need to sort of look at where our public health reserves could possibly be targeted going forward. I realise, Melanie, that they're mainly for Viv. I'm not bypassing you. I have no priorities here. Thanks.
Thank you, Councillor Doddy, and thank you for a range of really interesting questions there. So I'll try and take them in turn. We can take them offline if I don't cover some of your points. So first of all, in terms of the integrated sexual health service, you're right in terms of we're just coming to the conclusion of the recommissioning work. So tremendous amount of work has been done in terms of really understanding the needs of the Nottinghamshire population, what happens post-COVID, because we know that the way that people are accessing sexual health services has slightly changed. How are we absolutely making the most out of the technologies that are developing, and acknowledging there's quite a shift in a change in terms of how some people access services. So there's quite a lot in terms of moving into online access and people requesting tests that they send home in a confidential space. So the recommissioning and the service specifications taking into account of all of those different things, absolutely acknowledging that the universal service doesn't meet the needs of everybody, and so that there's that need for flexing. So whether that's particular populations in terms of particular geographical groups linked to deprivation, whether that's particular groups that we know that men who have sex with men, for example, have different sexual health needs, or whether that's thinking around particular ethnic groups and faith groups that want to access those. So just to sort of assure you, I suppose, that as part of that recommissioning and that new service model, we've absolutely looked at the needs of the population and made sure that we are commissioning a service that will meet those needs in a much more joint way as well. So one of the key ambitions around that service is to have a much more jointly commissioned service, working very closely with colleagues across the city, acknowledging that the flows of patients don't see the county and the city boundaries, but also thinking around how do we have a more coordinated services across the whole of Nottingham and Nottinghamshire. So does that cover your points in terms of the sexual health elements?
Yes, I mean the recommissioning and the going online, etc. We're as prepared as anybody, really, aren't we?
We absolutely are, yeah, and I'm really looking forward to seeing what the new service can bring for us in there. In terms of measles outbreak, a significant amount of work is being done in terms of the preparation for measles. We haven't got any confirmed cases yet, but we know that our neighbours, particularly in the East Midlands, now that measles is coming closer. So whereas before we saw it very much in sort of the big cities, London and Birmingham, we know that some of our neighbours in the East Midlands are seeing a much higher proportion of measles cases. So we're absolutely preparing ourselves in terms of doing that preventative work, in terms of really understanding where our lower proportions of vaccination uptake is, whether that be in our children who potentially may not have had access to the vaccinations in the way that they have following the COVID pandemic, whether that's understanding that the slightly older children that may not have taken up the offer, but also acknowledging that there may be a number of adults that haven't had their MMR vaccination or the measles, mumps and rubella vaccination, and the offer is open to all. So I think we're doing a lot of work around thinking around what can we do with our population to make sure that they are protecting themselves, and the absolute best way to protect yourself around measles is to have your 2 MMR vaccinations, which is highly effective, highly safe, and can give you lifelong protection. So that can really help in terms of protecting yourself from the really significant impacts of measles, where we do see a number of hospitalisations and we do have a number of long-term impacts. Unfortunately, some children and adults can have meningitis, pneumonia, and in some cases it can be fatal. So this is a really serious disease that we have got some tools in the toolbox to really work against. In terms of the actual preparation, we're working very closely with our colleagues across the system, really working with our health colleagues to really think around what the messages are, how are our services ready, so that if people know that if they have signs and symptoms of measles, that they don't necessarily go into those healthcare services, because we know that this is a really infectious disease. But also making sure that if those cases do turn up, that the response is there very quickly. And we've actually got some tabletop exercises already planned to really work through the nuts and bolts around, okay, if we had a case, this is what would happen, these are the implementation, these are the flows. So there are a lot of works going on in terms of understanding that preventative lens. Where do we need to do more work in terms of supporting our communities to have the confidence, the competence and the access for those vaccines, but then also testing the back end in terms of if a case does arrive in Nottinghamshire, how can we respond really effectively for that. And in terms of the detox work, I can take that offline with you if that's helpful in terms of getting some numbers for comparator.
Thank you for that, Viv. I think the MMR vaccination is preventative. It's a very important message we need to be getting out there. You know, it's something that's just gone a little bit lost in the ether a little bit. I think it's something we need to just ramp up a bit and to get that message out there to people. A bit more things. Is there any more questions from members? Callum, sorry.
Thank you very much, Chairman. So, in terms of finances, some of it is out of the council's control. So I know in the report it says that day-to-day services is going to be impacted with the city pulling out the contract. I was just wondering if any work's being done to almost either know the financial impact this will have or the service impact it will have. The other financial aspect that concerns me is the fee uplift as well. So increase in the national living wage, largely out of our control. And the RCB reviewing their work in terms of joint funded continuing healthcare. So there's quite a few financial risks there upcoming that we're almost, it's all national stuff that we can't really impact. So I suppose my question is the day-to-day service question, as well as what work is going to be taking place to almost mitigate the financial impacts on these potentially the more national stuff that we can't directly control. Thank you very much.
Yes, so adult social care particularly works as part of a system. So our people that we support will often have packages of support that involve other people. So whether that's accommodation that we've rehearsed a bit today, where others are responsible for that, or directly with health. So that joint relationship with health is really important. So what we have is a special review team that's led by Sue and Ainsley. So because this impacts older adults and working age adults equally, so people have support from both health and social care to try and have in place funding arrangements that agreed that meet the person's needs. So that's the way we're mitigating that, is trying to work really closely with health. But yes, what we can't do is control the decisions made in other organisations. The living wage made a significant impact on our budget. Because adult social care employs so many people, so I mentioned that 25,000 people earlier. So it's brilliant that people experience better pay. I would rather it was care workers rather than everybody had better pay. Being quite selfish, because I think care workers deserve to be compensated for that. But all we can be doing really is trying to make sure that people's needs are met in the most efficient way, and that we use technology and other methods as part of that, because even if money wasn't an object, we don't have the workforce in terms of being able to meet all of those needs. I'm not sure, Callum, if I've answered the question, but I think I've picked up on the concerns about risk.
Yeah, the main one was the day-to-day services for the city in particular. Personally, I would have thought, joint working would have almost been a cost-saving measure in itself. So obviously, I believe it's mentioned that if you can't go to the city because they have almost diverse range of day service, for example, is that cost going to be now on the county to fulfil? And if not, or if so, what work is going to be taking place to almost either compensate for that city arrangement or to build power and resilience, essentially?
Yes, I know we don't have any responsibility for city council residents, but it's more about when there are changes within the system. So it's both of these providers that work across the city or indeed the region. So when different organisations change their commissioning activity affects providers. So really we just need to be aware of that and have that upfront provider engagement. I don't think, Katie, there's any particular risk we're concerned about there. Is it just that we need to be mindful about, it's the same with when we change our commissioning and service behaviours that impacts on others. So it's just being mindful of it and being an active partner in that. But no, we won't have any financial direct impact with the City Council's finances in that way.
Yeah, just you raised some good points there, Callum, and just would very strongly want to advocate reassurance to residents across Nottinghamshire. So, in terms of the City Council and their current financial difficulties, it's something that I was very acutely concerned about here in adult social care, the impact it might have on us and our ability to work with the care authorities across Nottinghamshire and the direct providers of care home provision where there's significant overlap between ourselves and the city. And it's also something that's been raised and voiced quite loudly by the care community themselves, the Nottingham Care Association and others, and in terms of what that would also mean for the outworking of our fee uplifts in terms of care home management going forward over the coming months. And I cannot say loudly enough that I am very reassured that we are in a stable position, that the City Council also will be able to meet their fee uplifts. I believe that will be the case. I don't want to speak out of turn. So just to build reassurance, and in terms of this specific contract that's lost, it's new uptake going forward in terms of county residents, and we will cater for those in the services that we already have and the provisions we already have, and look to meet people's needs on an individual basis according to their own criteria. So I think I've said it as loudly as I can. There's no need to panic, and I'm confident that we will be in a decent enough position to maintain good services through the coming months and the coming years here in Nottinghamshire. Thank you.
Thank you, Councillor Barry. Councillor Pringle.
Thank you, Chairman. Melanie, 5 questions, which are short answers, I'm sure. Page 53, target for dolls 100%, we're at 65.3. Yeah, on dolls, yeah, 53, page 53. I did my own weekend. The new dolls provider as well, I wasn't aware that we're having a new dolls provider. I've obviously missed that somewhere. What's their contract time? There's a new dolls provider, yeah. The carers outcome as of the 30th of January. Are we getting an update of that response at all? Yeah, okay. The risk assessment map on page 77, seems a lot of red in there. Yeah. And then my last question is really because we're getting ever close to the 2nd of May, and as Councillor Bailey references our neighbours, I wonder if we're likely to pick up any negative impact across the mayoral combined authority at all, because it's not all sunshine and roses.
Thank you. You can tell us now.
So I think Sue's just left me at the point I need to ask about the new provider for dolls. But yes, our waiting times for dolls has increased as we're moving to the new arrangement. So a dolls assessment, I suppose it's quite similar to the approved Mental Health Act assessment you heard earlier. It involves a number of people, so it involves a best interest assessor, especially approved doctor. So there's a range of people that need to be lined up for that assessment. So there hasn't been sufficient supply across all of those professions. So that's led to the waiting times. We are concerned about that because we shouldn't have any waiting times under the legislation, regardless of the fact that our waiting time performance is better than others. That gives me cold comfort actually to say that our waiting times are less than others around me, because we have there is waiting time. So it's a real focus for us. I don't have any answers about the provider, but Sue can when she comes back, hopefully. And then in terms of the risk the risk log, we do have a number of risks. So one of the things that we've been introducing is the Care Data Matters strategy. So this is part of adult social care reform from the Department of Health and Social Care, because despite the narrative that adult social care reform is paused, it isn't actually. There are some things that have been progressing, and Care Data Matters is one of them, and that involves now client level data. So we need to publish data that relates to individuals and adult social care, and that's one of our big risks here, because that's changed the way that we manage data, our reporting, our data quality, and mobilising. That's been quite a big shift for us and our corporate colleagues managing the IT systems. So that work, we're not yet fully implemented it. So that's why that's one of the key risks that come up under the risk log on the heat map. But no, I agree, there's some of those areas that we wouldn't want to be seeing there.
So just on the heat map, the information and data, and apologies, because I thought the information and data that we spoke about earlier was being relatively well received by everybody and was being used by everybody. Is this a different thing altogether? Yeah.
Yep, so this is very specific about adult social care client level data, it's called. So it's part of the care data matters in policy by central government. So it's a new regulatory piece of work, and it runs alongside Care Quality Commission assurance. So before we would submit our data on a quarterly basis, and it would be some of the percentages that I think it was Councillor Owen commented on. It would be very broad. The client level data then takes all of that out, so it's going to be actual numbers about actual performance that's being published on us. And so we've been developing that alongside the government rolling it out. So the Department of Health and Social Care every month has been adding on reporting requirements. So we've got this sort of twin track reporting requirements increase, and then we work alongside that. Some of the data we can't report on in the same way, so it's had to have that systems development, alongside it, which is why it's been an ongoing piece of work for us.
Sorry, just the answer on the mayoral election.
Yeah, thank you, Councillor Pringle. So I've always, so you probably recall me saying in the past, I've been on a conversion journey myself with devolution for several different reasons. I was quite anti it in the early days. I'm now, the last good few months, I've been incredibly pro. One of the reasons I'm incredibly pro is not least in that what I hope will be some of the benefits which ultimately can come for the things like adult social care and public health. The closer and the more aligned we can work across boundaries and regional boundaries, the better. We've seen evidence of that demonstrated with our working with the City Council over many years now. The greater alignment, the greater efficiencies in terms of recruitment of staff, retention of staff, in terms of not duplicating services, in terms of trying to target and get growth in the right strategic areas where it's needed, and consequently in the areas where it isn't needed. All of those things, the more we can work together with the less people involved around the table to do it, the better. And on a bigger geographical region as well, that will absorb some of the implications of localised staff issues as well, and hopefully remove some of the competition factors that exist so strongly between. Now, all of that is said hugely optimistically, and I'm a realist as well, and I realise that those benefits are not going to be realised overnight, and the only way they ultimately will be realised is with politicians getting a consensus, getting in the way enough to care enough to get to the right outcomes, but then also getting out of the way with politics enough to get the good downstream measures that we need to enable every pound to be stretched as far as it possibly can, because the reality is, there's big challenges. We all know that. That's why the charts show so many reds. We're being honest, we're being transparent. This isn't all roses. There are warts and all, as I said earlier, in this stuff, but we're being honest about that and being in it together and trying to find a consensus that actually takes the adult response and moves forward on an intellectual basis is the right way to proceed. And I hope and I pray that devolution will enable us to do that here in Leicestershire and Derbyshire in a way that we've not been able to do before, in Nottinghamshire and Derbyshire in a way we've not been able to do before, and I hope also ultimately in Leicestershire and even beyond. That's my answer.
Can I just say, Chairman, I hope I wasn't being negative with any questions, because there is a timing to this and a responsibility which I think we need to be on top of, which are the questions I've raised. That's simple.
Thank you, Councillor. Excuse me. Sue, I don't know, you were out of the room. I don't know you picked up on the question that was referred. No, you didn't. No. Not to worry.
So apologies, I had a bit of a coughing fit. If somebody could repeat the question. Yeah, it's a positive situation. It's important to say that it's also provided. There's two aspects. One is a social worker who's qualified with an additional best interest qualification that's been very short supply nationally, and the other bit of the contract is for is for mental health assessments from a doctor. The mental health assessments, they've been performing well since day one, so that bit of the contract has gone well. They're doing a lot better. They're gradually improving since they took on the new contract. But because they weren't where we wanted them to be with the social work BIAs, we've reduced the amount that we're expecting from them, and we've gone out to other agencies to fill that gap. So that's why we've got a steadily improving position. We'd also we've always used the agency contract if we haven't been able to recruit enough of our directly employed staff. And really positively, we've seen an increase in our in-house team to be probably the biggest it's ever been. So it is an improving position.
Thank you. Councillor Prima. Yeah, Councillor Prima.
Yeah, just a quick, very quick one on just seeking some more reassurance from Council Party in a minute, I think. But bullet point 59 about the current finance position, that some day centre services have been affected across the city and ourselves. And there's an excellent facility in the Gedling area, which we put our tenants in, but at the same time it's run by the city. So I just want some excellent reassurance that certainly at this moment in time that our facilities are secure, regardless for day services, because we do actually have joint working with them, and to a very large extent we actually don't know what the Commissioner is going to do. So just seeking reassurance about that particular facility. I don't want to name it in public, but I think you know which one I'm referring to. I can name it if you want.
Name it, Jim. Nobody's got a clue, mate.
Earl's Court.
Apologies, I'm 8 weeks in, so I don't know all of our day centres provision in depth yet. I'm not aware that we're overly concerned about capacity, and I certainly know that we'll be looking at where we've got provision, what we're using it for, but also some of the movement that we're seeing nationally as well, and we'll be doing locally, looking at how we support more people with day opportunities in their community rather than a specific building-based centre. So we'll be looking at both of those things going forwards, but I'm not aware that we're particularly worried about any specific provision.
Yeah, thanks. It's just reassurance because it is so close to the city. My patch is literally on the city border. This one is it's only about 1.5 miles, 2 miles roughly from the city border, and our facility, but at the same time it's run by the city council, so it's just a little concern.
Yeah, I think we got it covered. I think Councillor Barney wants to.
Yeah, just to say, Jim, that there's been a wider piece of work going on for several months now, and it's still ongoing, looking at day opportunities as a subset and looking at the council services in relation to day opportunities across the whole of Nottinghamshire. And that work is ongoing. There's been quite a few changes just in the underlying demographics of uptake of use of those services in some area. So we've seen a fluctuation of demand in terms of resources and in terms of the provision that's provided as a whole across Nottinghamshire. That's why the review is being undertaken. But that review is very much about ensuring that we have the right level of day opportunity services in the right places, doing the right things, and ever more increasingly trying to provide a more targeted response to how we respond in terms of day opportunities. If you think back 20 years, the way day opportunities are offered in this country are very, very different than how they used to be, from where basically we used to effectively put people to work for no pay, to now hopefully offering people the best prospects to enhance their own lives, to get the most out of their lives, to maximise their own skills and abilities, to have a fulfilled life in the same way that any of us would expect. So that's the ethos behind the opportunities review that we're currently undertaking, and I hope that will provide better service going forward. In terms of your specific question, if you could email it, we'll look into it for you happily and give you the detail you want.
Thank you, members. There seem to be any more questions. I think we can safely say that our health performance and financial position is in good hands. We're dealing with services that are always under constant pressure from different areas. I mean, the City Council is one instance. Which just popped up, and and we have to deal with it. So I think well done for the team on that. Are there any other? And also, actually, I think Councillor Barney and Councillor Colton are actually busy spending the £9.5 million in reserves, so let's hope it's spent in a positive way. Although I think money's a little bit ring fence, isn't it? Yes. Martin.
I don't think there's anything else to add. I obviously will go on to this in the next item, but just what Councillor Dolly was saying about the new sexual health services, that might be an area that members want to consider looking at when it's been in place for a while to see how it's see how the new services is running. So we can probably put that as an item to be considered for next year's work programme.
Thank you. I move the additional recommendations. Seconded. Okay. All those in favour? Thank you very much. That's unanimous. We now move programme, Martin.
Yeah, the work programme is just there to note for your information. Obviously, we've got the suicide item coming up at the June meeting. Obviously, that is then the last meeting that's on this cycle. And then work will be taking place after that meeting to start developing the work programme for next year. As always, keep your eye on the forward plan. If there's anything you're interested in, please let myself and the chair know. Or if you've got any general suggestions at any time, you don't have to wait to voice them in committee.
Thank you for that, members. Callum.
Thank you, Chairman. So I've just joined this committee in December. I'm just looking through it. I know in the agenda, I think it said there was items to go to committee members by the 31st of January. I don't believe I've received some of them. So the adult social care reform on page, what I'm referring to, I don't have pages, but adult social care reform, and then it mentions about sector-led improvement. And cost living programs as well. It all mentions to be circulated. I don't know if I've received those or if anyone's received them. So
we'll get that chased up, and we'll let you know about. We'll let you have some revised dates this week.
Yeah, and I suppose the other thing as well, in terms of some of the items, I think there's a few duplications, in particular about substance abuse and smoking. I noticed in the forward plan, I believe Councillor Carlton has an item coming up in terms of the smoking strategy. I'm not sure if those can all be linked together in some sort of item that we can look at at all. Just a few things I picked out when I was going through it initially.
Yeah, I'm sure we can do that.
Thank you, Councillor Bailey. Yeah, we will know the work programme is working, and I think it does want a bit more fine tuning on. There's a lot in there that probably does sort of double on the health scrutiny as well as what we do, so we need to probably just going through things. But also, as Martin just said, the forward plan is a very important document for us to pick up on things coming forward that we feel need scrutinising. Councillor Pringle.
Yeah, I just wondered if we could formally invite Councillor Lee Brazier from Ollerton to the 3rd of June meeting, referencing the suicide in particular. Is that possible?
I don't know. I've run it past the members, I know we have outside people.
You can invite anyone.
Okay.
Yeah.
I'll put that as consideration. Thank you, Councillor. Thank you. To know the business, I will thank everybody for input today. It's been some very, very good debate. Sorry? Oh, do we vote on work programme? We do indeed, sorry. Do you like to vote then, Councillor Gary? Anyway, thank you very much, everybody, for your input today. It's been quite a long meeting, but I think it's been a very valuable meeting. Thank you.